Pleasure to be with you. Good afternoon. We're going to talk about chronic constipation in long-term care today, and before I even get started, I'll apologize about any colloquialisms I may use during this discussion. It's hard to talk about this subject and not use a colloquialism or poke a little fun here and there, and gosh sakes, so we have to do some disgusting things to show the love we have for those who are in our care, and this certainly is one of those areas. There's a definition of chronic constipation out there. Now, when patients define constipation, they do it based upon symptoms. People that have to strain at stool, who have hard stools, who have inability to have a bowel movement. The slide says laxation. By the way, that's doctor talk for a good morning sit down. And then people will complain of feeling that they have inadequately evacuated their bowels. Now the doc is talking a different language. And physicians typically throughout history have defined constipation based on frequency, and typically that has been a definition of 3 or fewer laxations, bowel movements, within any 1 week. That's an unreliable definition. I mean, you got to go by memory unless you're doing a diary of your BMs, which not too many people do. If people do a diary of their BMs, you got to be a little concerned. In order to step away from that kind of a totally frequency-based definition, researchers in this area, yes, there are researchers in constipation, they came up with Rome II criteria. And the Rome II criteria, which again are a research definition, would be that at least 12 weeks out of the preceding 12 months, there would be 2 or more of the following criteria met. So you don't have to have all of these, just 2 of them. One would be straining at stool more than 1/4 of the time. Another would be lumpy or hard stools. Another would be sensation of not completely emptying your bowels 1 out of 4 times. Another would be a sensation of anorectal obstruction, like there's something blocking you off with 1/4 of your bowel movements. Yet another is manual maneuvers needed to facilitate evacuation in at least 1 out of 4 bowel movements, and not a lot of people will come in and volunteer to you that they have actually done some kind of a manual maneuver, like use their finger or something to get BM out. So this does require that the caregiver be a little bit insensitive to propriety and ask. When I think of this one, I think there's the story of the constipated mathematician. He worked it out with a pencil. Now, the last criteria here is less than 3 laxations, 3 bowel movements in a week, and that goes all the way back to the old historical definition for physicians of constipation. In order to have this meet these requirements and get the diagnosis of chronic constipation, one must also not have loose stools in between times. If a person has alternating constipation and diarrhea, that should set the physician to thinking about a condition called irritable bowel syndrome, and would be an exclusion criteria for the definition of chronic constipation. To give you an overview of the risk factors for constipation, being female is more likely a risk than males, and that works out to be about a 2 to 3 to 1 factor. Certainly, the older you are, the more likely you are to develop constipation, and somewhere between 15 and 30% of all elderly people are going to show constipation. Now, there's a relationship between constipation and activity level and otherwise ill health and so forth, so that if we take the elderly who are in nursing homes, and if we look at the frequency of constipation, the likelihood of constipation, based upon how many people have laxatives written on their chart, that number is somewhere between 50 and 75% of all of our nursing home residents. Being in a lower socioeconomic class makes you more likely to be constipated. If you're not Caucasian, that increases the risk. If you have a lower educational level, if you have a sedentary lifestyle, if you are a couch potato, you're more likely to be constipated. And there are a number of medications, and we'll get into that in a little bit, that can make you constipated. If we look at classification of constipation, not all constipation is caused by the same thing. And there is one category in which the transit time, the time that it takes for your sandwich to make it to the commode, is normal. And so there's something else going on that's causing one of these other symptoms on which we define constipation. Defecatory disorders are problems in actually getting the bowel movement out. It's down in the vault, it's right there by the anus, and there's a problem getting it out. Defecatory disorder. There's a slow transit constipation in which it takes a longer than normal time for your sandwich to reach the commode. And then there can be combinations of the two, defecatory and slow transit types of constipation. What's in a bowel movement? Have you ever asked yourself that? Well, if you have, you got to maybe stop and make a run into your psychiatrist. But let me answer that unasked question. What's in there?